So today's agenda will include information about the structural heart team and the MitraClip procedure, and it's Dr. Matthew McKay is with us today. So during this virtual session, Dr. McKay will cover details about the MitraClip procedure. He'll speak about patients that may be good candidates and how to connect with the structural heart team, and details around referrals for your patients. At the end of the session, you should receive, I'm hoping, an email with a survey. So this information that we have received in the past from surveys has really allowed us to better offer sessions for our public and our providers. So we would encourage you to complete the survey after the session ends. So now I want to introduce Dr. McKay. Dr. McKay is a cardiac interventionalist and structural heart specialist here at Northern Light Cardiology at EMMC. He's also the medical director for our growing structural heart program. A graduate of Cornell, Dr. McKay completed an internship and residency at Beth Israel and fellowships in cardiology and interventional cardiology at Columbia. So his resume is extensive and it's very impressive. He's earned numerous licenses and certifications and has participated in a number of clinical research projects. He's a fellow with the American College of Cardiology and holds several professional memberships. So a native of New York, he's been with Northern Light Eastern Maine Medical Center since 2005. So we're glad you're here, Dr. McKay. If you'd like to take it away, and we'll let you launch right in.
Thanks, Amy. Thank you for that introduction and for the opportunity to speak. So I have no ties to medical industry whatsoever. The goals of today's presentation will be, one, to provide the audience with a brief clinical overview of the problem of mitral regurgitation with a specific focus on the potential role for TEER. Two, to review highlights from the 2020 update ACC AHA guideline on the management of valvular heart disease and MR. Three, to summarize published trial data supporting the use of TEER for MR, and to review current registry data, including US STS data, to better understand what's being done around the country and what outcomes are looking like in the quote real world. And then finally review the evaluation procedure process for TEER at Northern Light Eastern Maine. So speaking on the prevalence of mitral valve disease, it's a very common problem, especially as we get older. So looking at age over 75 years old, you can see that about 10% of the population is faced with significant mitral valve disease. And that's probably about double of the number of patients that develop aortic valve disease. When you look at our ECHO database, I did a query a couple of years ago from 2013 through 2016 to get a feel for how many cases we were diagnosing on our TEEs with moderate to severe or severe MR. I found that it was about 110 to 120 cases per year of having that kind of mitral pathology. And if you compare that to, say, the number of diagnoses of severe AS over the same periods, that was about 70 per year. So the 2020 ACC valvular heart disease guideline asks us to think about valve disease and categorize it similar to the way they ask you to do with heart failure. So in stages, they want you to recognize the population that is felt to be at risk, in particular aging, other factors, patients that have developed an element of valvular disease in the mild to moderate range that are being watched, those are the Bs. And then the patients that develop severe mitral regurgitation would be categorized as C if they're asymptomatic and D if they become symptomatic. And then the C's are broken down, the asymptomatic C's are broken down into two categories. There are ones that are starting to show signs of dysfunction of the heart, of the ventricular function or size. Those are the C2s, and the C1s still are looking like normal hearts despite having severe MR. And then I'm gonna just move this thing 1 second. It's just sort of blocking my slide here. Sorry, there we go. So for people that are seeing patients, at various stages, of valvular heart disease, a lot of our referring providers, this slide just highlights the ACC recommendation for who to get echoes on and how often. So if you're a stage B patient with moderate mitral regurgitation, regardless of symptoms, these are patients that PCPs should be getting an echo on about once a year or every one to 2 years to look for some of those changes that can happen in the ventricle, even if the patient feels fine. And then if the patients are really truly only mild mitral regurgitation, you might stretch it out quite a bit longer, up to 5 years if it's really not very impressive. If you reach the severe category, that's where you have to be careful because changes in the ventricle can sneak up on you. And you might even be doing surveillance echoes like every 6 months. That might be a patient you just decide needs to be followed closely, either in our structural clinic or by cardiology. So the clinical presentation of mitral regurgitation can be summarized by saying that most cases of mild to moderate MR are basically asymptomatic and not with any indication for treatment at all. The patients with moderate to severe MR, as mentioned in the previous slide, can cause cardiac dysfunction, even in the absence of symptoms. And in the setting of a dilating ventricle, decrease in ejection fraction, sometimes pulmonary hypertension, or development of AFib might be considered for surgery, even if they're asymptomatic. Symptomatic patients who are short of breath because of the MR have an indication for mitral valve intervention. And the classic description we hear all the time is that there's a unexplained abnormal shortness of breath with exertion, and often even with reclining in a recumbent position. And the other thing to keep in mind is that mitral regurgitation is very dependent on the loading conditions, your blood pressure, your heart rate, and other factors. And there are some patients that have what appears to be only mild to moderate MR at rest, but then can develop more severe MR with exertion, explaining a severe exercise intolerance. So if you have someone who has, a solid MR that describes feeling a lot worse than the resting echo looks, the little insert in there is to remind us that ACC considers it a class 2A indication to do an exercise echo on them to see if the MR gets worse. And then on exam, the classic findings, a holosystolic murmur, often at the apex radiating to axilla. You'll hear it a lot, but unfortunately, the sound by auscultation is not very predictive of the severity of the MR. And, you really should be doing an echo for that diagnosis. Mitral valve pathology by convention has basically been divided into two main categories. So primary MR, what we call degenerative, just means that there's a problem with the leaflets not being healthy. That's, myxomatous degeneration, calcification, inflammation, fibrosis. The leaflets have gone bad or they're partially torn, and the MR is because of that. Secondary MR is a whole different can of worms. That's what we also call functional MR. And that's basically, we'll just think about that as our heart failure population. So patients that have reduced ejection fraction, who are dilating their hearts, the mitral valve annulus becomes dilated and they get worsening MR, which then basically just makes the whole problem worse and accelerates the heart failure. So those are two kind of big categories. Natural history of mitral regurgitation is not great. So this is a slide from Bromwell just highlighting that, if you go out 5 years with severe mitral regurgitation, you're talking about survival of somewhere between 40 and 60%. So a lot of patients are dying if the mitral regurg is left alone. Fortunately, if you correct the mitral regurgitation, and the most elegant way to do that is with a mitral valve repair, things go fine and you act more like the rest of the people your age. So the little dotted line on the very top shows, the survival curve of the regular population. And then right underneath it, that dark black line is basically paralleling it. That's with patients who get a nice repair. The patients who end up needing their mitral valve replaced do a little bit worse. You can see that drop off, especially in the first 6 months of survival. But they still do quite a bit better than patients who never had mitral valve surgery at all. So this ACC insert is really just to highlight their emphasis on specifically evaluating the risks of procedure for every patient in terms of risks with surgery and with risks of the new interventional tools. And that there should be some shared decision-making with the patient about what they decide they want to do. The other thing they come out and say is that they consider it a class 1 indication that this discussion happens with a multidisciplinary heart valve team. So that's basically what our structural clinic is offering. The procedure itself is minimally invasive. So I think, basically the procedure is done under anesthesia because you have a TEE probe down the esophagus, and that's uncomfortable to leave the patient awake with that. But the surgical part of it, if you will, the interventional part of it is minimally invasive and pretty painless. We make a puncture in the femoral vein in the groin, put a catheter up to the heart, just like doing a right heart cath. We do a transeptal puncture to get from right atrium to left atrium, and then insert a wire into the left atrium. And in doing that, we can pass a steerable guide into the left atrium that has a number of knobs on it that can steer you in 3D space. And you get the MitraClip put in a position right in the middle of the mitral valve leaflets so that they're perpendicular to the line of coaptation of the valve, and clip them together and basically reduce the amount of regurgitation just by improving coaptation. So it's kind of a stitch or clip generally in the middle of the valve or just off to one side or the other. And then the echo images to the right, show above the mosaic of color going from ventricle below to the atrium above with severe MR. And then you can see the shadow of a little V-shaped white clip in the lower image where the mitral regurgitation in that particular case is amazingly reduced. And then the steerable guide comes out, the atrial septum heals by itself. There's one stitch put on the femoral vein that stays in. There's no incisions in the body, and that's it. So TEER was primarily first studied for primary MR, the degenerative kind. That was the Everest 2 trial that was published in New England Journal in 2011. They basically looked at patients that were felt acceptable for surgery or for the MitraClip procedure and randomized them. And what they found was that the MitraClip wasn't quite as good at reducing MR from severe to trace or mild as surgery was, but the patients did well anyway and had similar improvement in shortness of breath, similar improvement in hospitalization for heart failure, and less complications than the patients who had surgery. So that got people thinking. And if you looked at subgroups in that trial for patients that were age over 70, which is obviously a lot of our population, it looked like there was possibly near equipoise between surgery and MitraClip. For patients also that had reduced ejection fraction, the two procedures appeared pretty comparable. And there's some ongoing studies that are looking at MitraClip for degenerative MR. Besides Everest 2, the NIH trial is looking at all comers, basically over the age of 65. So that result should be interesting. The repair MR is looking at moderate risk patients. And then the MITRA HR study is another one in France looking again at high risk patients. So based on the information we have so far, importantly, the TEER or MitraClip procedure was upgraded in the latest ACC guideline to a class 2A for patients that are felt high risk or patients that are prohibitive risk for surgery. So in terms of how you think about surgical risk, basically, if you look at that third column, what we mean is that the surgeon calculates or predicts in their opinion that the patient's faced with an 8% risk of a major problem. We're also talking about patients that have 2 or more indices of frailty. We're talking about patients that have basically just one other organ system that is compromised significantly. So maybe severe COPD or some element of cirrhosis or renal failure. That's enough to be considered high risk. Or there are procedure-specific impediments like a hostile chest and stuff like that. And then the prohibitive patients are obviously just worse. For a low-risk patient, somebody to be considered for surgery when they have, minimal symptoms, they're just being very aggressive, you better be assuming a risk of less than 1% for that kind of mitral valve surgery. Just a brief thing on frailty, we calculate this in our structural clinic for all the patients that come in, and it's basically a scale based on 4 factors. One is being able to do 5 times standing up from a chair and sitting back down in less than 15 seconds. Presence of any cognitive impairment based on the interview and input from relatives. Presence of anemia and presence of hypoalbuminemia. So if you're a 0 or a 1, you're pretty much not frail. You can do just fine with surgery. The 2 to 4s make you pause on surgery. Maybe you're thinking catheter-based procedures more. The 5s are very frail people. They don't really do well with anything. So some of those are more palliative. So this slide just summarizes the pathway that the ACC wants you to use when you think about how to deal with a degenerative or primary MR case. Essentially, if you have severe MR and you have no symptoms at all and you want to be super aggressive, that's on the right side of the screen. You can get into detail on some of the factors like your pulmonary pressures, the size of your ventricle, etc., and decide about whether you want to have a low risk mitral valve repair. If you're on the left side of the screen, that means that you have severe MR, and down the middle, if you have LV dysfunction developing, you need to be considered for a mitral valve surgery. If you go to the left there and the surgeon feels they're high risk, it's a 2A to go ahead and give those people a chance at MitraClip if the anatomy is suitable. And then same thing on the upper left there. If you have symptoms of severe MR, you got to consider surgery. Again, if it's felt to be a high risk for open heart, it's a 2A to be looked at for MitraClip. So that's it for the primary MR. Secondary MR is a whole different population. So I kind of split the talk into 2 halves. This group is the heart failure population. So those are people with reduced EF. Now, 4 to 5% of people with low EF have severe MR. Up to 12% have moderate to severe MR. So altogether, you're talking, getting close to 1 in 5 people, 1 in 6 people have significant MR when they have heart failure. And it's associated with worse prognosis. So this slide, looking at low EF patients going out, let's say in the middle of the graph, 4 years, if they have severe MR, their survival is only like 50%. If they didn't have that MR, it's higher, more 75%. So it makes a big difference. The association is there. So it made sense to look at the MitraClip procedure for functional MR as opposed to surgery for primary MR, which works well. when you operate the open heart on heart failure patients, they don't do very well. So surgery is really not proven as a standalone procedure for those patients to lower their death or hospitalization. And there's plenty of room, plenty of possibility and concern for complications. So co-op trial basically was done randomizing heart failure patients to MitraClip versus just standard heart failure therapy. And what they found was that the MitraClip resulted overall, when you summarized all the data, in a improvement in mitral regurgitation, a reduction in hospitalization for heart failure, improvement in quality of life, and even reduced mortality when you take all the data in sum. The post-approval study that has been following everybody around the world, who has had a MitraClip, and now it's about 5,000 patients, has also yielded helpful data to help us understand how these patients do in the real world, and I'll show you some slides on that. So this clip just reminds us, how the ACC wants us to think about heart failure therapy. So they consider it class 1 indication for these heart failure patients with a lot of MR to all be on guideline directed therapy. That means appropriate dose ACE inhibitors or ARBs, beta blockers, aldosterone antagonists, or Entresto, and even CRT if they have a wide complex QRS. They also considered a class 1 indication that when you're optimizing these patients prior to deciding about clip, that should be done by a heart failure specialist. So how does the clip do in terms of reducing MR? If you look at this slide, the bar to the left in red shows, that about 95% of the patients had moderate to severe or severe MR to start. And at 30 days, very few, 5 to 6% of patients, 30 days and 1 year, had moderate to severe MR. The bulk of them in green had only mild, and about 30% in yellow were left with moderate MR. And it held up pretty well between a month and a year. So the impact on MR reduction is pretty impressive. What does it do for your outcomes? So these two graphs show 3-year data post enrollment in the co-op trial. On the left is all-cause mortality. That was significantly different between just heart failure therapy and MitraClip going out 3 years, and hospitalization for heart failure on the right, also significantly different between MitraClip and just heart failure therapy. And it turned out the number needed to treat to prevent 1 death in this study was only 7. And if you compare that to, say, using Entresto versus ACE inhibitors, you need a number needed to treat was around 40, for CRT 10. So the potential impact of the therapy seemed like it's fairly robust. Quality of life also is documented to significantly improve based on the KCCQ score. This slide is borrowed from the most recent European Society of Cardiology meeting this year that basically showed that the real world patients, those 5,000 patients in the registry are in red. Their outcomes pretty much paralleled the outcome for mortality, heart failure in the co-op trial, the randomized trial. So that was reassuring that, what was happening in the real world seemed to be behaving similar to what we saw in the trial, and in a much larger number of patients. And it was better than the blue line patients who were just on the medical therapy. And this is heart failure hospitalization. That was spread out even more between the blue medical therapy people and MitraClip people. And interestingly, in this one, there was even a hint towards the modern, real world use yielding even better results than the randomized trial in terms of keeping people out of the hospital with heart failure. this slide just kind of summarizes how you change New York functional class, New York Heart Association functional class. So at baseline, the majority of people were class 3, some class 4 heart failures. And then at 30 days and 1 month, pretty much, 3/4 of the patients were like New York Heart Association 1 to 2. 20% were still left with class 3 symptoms, very few left with class 4. So clearly an improvement in NYHA class. In terms of adverse events, I mean, the thing that's been so reassuring to see is that because the clip procedure is so minimally invasive, it has not really been associated with much complication. So for an 80-year-old population having this procedure, 1-year rates of stroke, very low in the randomized trial, and comparable in the real world experience, very low rates of heart attack, probably similar to what their age match, other patients are. Leaflet detachment off where the clip breaks free off of one of the leaflets happens very rarely, basically 1 to 1.5% of the time. Full device embolization where the clip just basically breaks off and embolizes, much less than 1% of the time, so very rare. And then needing reintervention on the mitral valve, also pretty rare, around 3%. So based on the original randomized data and then the registry data on thousands of patients, the ACC/AHA upgraded tier to a class 2A indication for heart failure patients that have moderate to severe MR with persistent symptoms despite standard therapy. So that was new in 2020. This slide is just meant to give you a feel for what's going on around our country. This is the US STS-TVT registry for all valve procedures, and this is the mitral stuff. The United States map there in the upper left corner kind of shows implanting centers, and you can see us up there in Maine. It looks like there's been about 34,000 patients treated. The mean age is around 80, so these are generally older people, half of them roughly male, most of them white. Length of stay towards the latter years, just a day in the hospital. Mortality's quite low. Functional class improvement, class 1 to 2, 80%, similar to the slide I just showed before. Majority of the patients without severe mitral regurgitation, which was only an 8.7%. And then not uncommon to have some mitral valve gradient after you clip the valve. So 26% had a gradient of at least 5, but they seem to tolerate that well, especially the heart failure patients. And they seem to think it's better to live with than the regurg. This slide just gives you a sense of what people have been operating on in terms of whether it's primary MR or heart failure patients. The heart failure patients are in red, the primary MRs are in blue, and then the other colors are mixed. I think that you have to take this slide with a little grain of salt because the heart failure MR population really wasn't approved until 2020. So I think people are really trying not to label their cases as functional MR. I think you might be seeing more listed as primary MR than they actually were, but the proportion of cases for heart failure patients seems to be increasing, especially since the change in the guideline. These are just our own US registry on complications. They're very similar to the ones published from Abbott. This summarizes ACC pathway for secondary functional MR. So they want you to get optimized by a heart failure specialist. If you have severe MR and you're undergoing CABG anyway, then they do a mitral valve repair, often with a ring at the time of CABG in the OR. If you're not going to the OR and you have reduced EF, that's your classic heart failure patient with low EF with severe MR, it leads you down to the 2A indication for MitraClip if the anatomy is suitable. So that's kind of summarizes how to think about it. If the EF is preserved, and that's the pathway to the far left there, indication for MitraClip not so clear. So referring to our clinic, we have two coordinators that have been leading things, Andrew Hansen, Diane Hill. We have other people coming in. They're very reachable, very helpful. If you call the number, they can help help you figure out whether the patient would be well served coming in to see us or get some other tests. They can talk on the phone beforehand if needed. If you just want the patient seen, most of the time we can do that within a month, and then they'll arrange for the necessary tests we need anyway. So the workup includes the patient needing to come down to Bangor to have a TEE done. That's reviewed by our structural non-invasive cardiologist. We do ask for stress echoes on some of the patients to look for dynamic MR. Many of the patients we ask for heart caths on. If they have major coronary obstruction, they may need to have stents. Once they get to the clinic, we review all the test results. We do the frailty test. The heart surgeon's in the room with the patient and family. The cardiologist, the non-invasive cardiologist is there, and the structural interventionalist is there. And then you get notes in the chart from both surgery and cardiology. And then we tell you whether or not, things just need to be observed, whether things need to be more optimized in a heart failure clinic, whether they can go ahead and get booked for TEER, whether it's better for them to have surgery or whether they're better just palliative. What does it look like to go through the procedure? Basically, they get extubated right in our cath lab. They get one stitch, like I said, on the vein that's internal. They go to the cath lab recovery room and then get admitted to a regular tele floor. They get an echo the next day. If things look good, they go home on day one. Then they have to come back to the clinic with a transthoracic echo in a month and a year. They need antibiotic prophylaxis lifelong for dental work, as with all valve procedures. And the MitraClip can be put in some MRIs. So summary and conclusions, moderate to severe mitral regurgitation is not uncommon in our patients, probably even more common than aortic valve disease, and is associated with significant morbidity and mortality. Mitral valve surgery for many of the patients in our region may be associated with significant risk, and TEER has now been shown to be a relatively low risk procedure with proven benefit, so should be considered. It was upgraded to a 2A recommendation for primary MR, felt high risk for surgery, and it was upgraded to 2A for heart failure patients that continued symptomatic despite optimization. And so a final thought is, considering all the data I presented today, I wonder if we're underutilizing the TEER technology in our system. And thank you.
Thank you so much, Dr. McKay.
Yeah, thank you so much. That was really a fantastic overview of the MitraClip device. You summarized nicely the Everest study and the co-op study and the recent updates in the valvular guidelines. This treatment seems to be a safe, feasible, and effective in patients with moderate to severe MR and primary disease, based on the Everest trial, and moderate to severe MR in congestive heart failure patients with low EF, based on the co-op trial. I haven't seen any questions coming up in the chat box here, but I was wondering if we could go over again how we approach if we see a patient in the office or in the clinic who has severe MR but is asymptomatic. What are the things that you look at when you're evaluating that kind of patient for MitraClip or surgery?
Sver, do you mean a heart failure patient, you said, or?
Yeah.
Let's
start with the heart failure patient, and then we can move over to the primary type.
Yeah, I mean, I think that I think it'd be ideal if we had those patients sort of getting optimized in heart failure clinic. You know, we just had a trigger to identify the ones that have moderate to severe MR, and then a process, you know, where there's checklists to make sure they are on optimized therapy, and then get, I think, visits with someone in heart failure clinic on an interval basis to check in to see how their symptoms are. You know, I think that symptoms are going to be the primary driver for the clip. And so I don't know that we're going to be screening too many people asymptomatic for the clip, you know, if they're perfectly happy with how they feel. I do wonder if we're under appreciating symptoms, though. I mean, you know, I think we get used to hearing patients live with heart failure and just kind of, you know, accept a certain level of dysfunction. And, you know, perhaps some of them we would think about differently depending on how we interviewed them. So, you know, I think just be aware of that the technology could possibly get them better than they are. So, you know, think about that when you talk to them. And don't think about the MitraClip as a major surgical procedure, because it just, you know, it really is showing that low risk kind of, you know, it's a low risk type of procedure that can possibly impact symptoms a lot. And so I don't think the patient has to think of it as this huge thing. You know, so maybe just in terms of how we interview patients, you know, are they symptomatic or not?
Yeah, I absolutely agree with you. I think sometimes this signs and symptoms can be subtle. When you dig deeper into the history, you can sometimes capture things like the patient has been slowing down, or if you ask, you know, spouses or family members, they have noticed that they've been more short of breath with particular activities, but the patient himself or herself has not noticed it yet. But I completely agree, for the heart failure population, it is indicated that they be optimized prior to evaluation for MitraClip. They should ideally be on the 4 classes of medications, meaning the ACEs, ARB, or Entresto, beta blockers, spironolactone or eplerenone, and the newer medications, the SGLT2. And if they have an underlying left bundle block, they should be evaluated for IV ICD or CRT, and if they have AFib, then that should be addressed as well prior to proceeding with the MitraClip.
One way I guess we might think about Sphere is like, you know, we're not really necessarily looking for decompensated heart failure patients that, you know, are edematous and just doing horribly, but more of the patients that are NYHA3, they're doing okay on meds, but, you know, the fact, if they do have moderate to severe MR, they could be an NYHA1 or 2 if they got clipped. So, you know, I guess it also, you know, depends on how we're looking at them.
Yes, I agree.
Functional class may be, you know, one way to classify a little bit better than, you know, just waiting for overtly, you know, sick patients that are doing horrible.
Right, I absolutely agree. You know, I think the patient with heart failure and reduced ejection fraction who is left with disabling dyspnea or fatigue despite optimal medical therapy should be definitely considered. One question popped up here that relates to symptoms, and the question is whether we would ever do a stress test or stress echocardiogram for asymptomatic patients.
I think so. I think, you know, again, on the symptom thing, I'm not sure that we're always the best at interviewing patients to understand their symptoms. And so sometimes exercise testing just makes it more obvious. I mean, I can't tell you how many aortic stenosis patients have told us they feel fine, And then when you ask them to go on the treadmill, like they're literally falling apart on stage 1, which, you know, for those of you that have been on treadmills, you know, it's barely moving. You know, so how they describe themselves isn't always the same thing as, you know, how they perform on an exercise test. So I don't really see a problem with having more patients prove it to you on exercise tests. And, you know, so you get that functional information from how long they go and what their complaints were. But, you know, if you're wondering if the MR went from moderate to more than moderate, you can get that information at the same time.
Yes, I agree. I think stress testing in this scenario could give you additional information and uncover some dyspnea or decreased functional capacity, which could give them the indication for moving forward. But if we look at the primary MR patients, one question came up about, you know, the echo parameters and other parameters that we use for indication for either mitral valve surgery or MR. If we could review those again.
I would say that the guideline seems to suggest that the clip can be used for patients that are dropping their EF or dilating their ventricles, even if they describe themselves as asymptomatic. Some of the more subtle indicators for surgery, like presence of elevated pulmonary pressure, new onset AFib, things like that. Yeah, we don't have a clear guideline for the clip in those, but they do allow the clip to be placed in an 80-year-old that's starting to drop their EF or starting to dilate their ventricle.
Yeah, that's a very important point. You know, I typically quote the 60-50-40 rule from the valve guidelines. You know, EF less than 60, pulmonary pressure above 50, and then left ventricular end diastolic diameter greater than 40. So these are all markers of remodeling from the mitral regurgitation, if you will, and AFib is in there also. So those are all great points to keep in mind. One question here about complications from MitraClip versus mitral surgery. Are there huge differences? What to expect in these patients?
Yeah, I mean, I think that the complications from MitraClip procedure are just tiny. We just are not seeing a lot of patients have procedural related complications. Surgery comes along with all the risks of open heart, you know, prolonged ventilation, renal failure, bleeding, need for transfusion. The prolonged ventilation and need for transfusion, I think, were the drivers for the adverse outcomes in the surgical arm of the trials. But, you know, I think that in the real world, you know, there's some deaths in there, there's some strokes in there that we are just not seeing with MitraClip. You know, I don't think we've had a MitraClip patient wake up with a complication. And, you know, you're not really, you're not invading the body in that kind of way. I mean, it's a venous puncture, it's a transeptal puncture, but those are being done so routinely in the EP lab now and in, you know, other structural procedures that, you know, it's all done under ultrasound guidance. The harm being done from the procedures is really quite low, but surgery for an 80-year-old is surgery. You know, it's not always easy to recover from. So I think the differences are pretty big.
Yeah, I absolutely agree. And I think the series and studies looking on the surgical population, on average, I think the perioperative mortality has ranged between 1% and 4%, and the risk of complications from surgery is around 10%. Kidney injury, stroke, prolonged ventilation, bleeding. And that risk goes up considerably in patients above 80. Which led to the design of the MitraClip and transcatheter options for this patient population.
And that was the average age of, you know, the patients getting MitraClip in the STS registry right now. So, you know, these are older people. You know, I think that there's a tendency to think that an older person who's, you know, just getting by is good enough. I guess I'm just questioning whether or not that's how we should think about it. You know, maybe they could be doing better.
Another question here. So how do we follow up with our MitraClip patients? Do they need regular or scheduled surveillance echoes or TEEs? And do they need anticoagulation, or is antiplatelet therapy enough?
Yeah, we haven't used anticoagulation therapy just because they had the clip. The registry mandates the 1 month and 1 year echoes. So we take care of that. And then after that, the recommendation is annual for for TAVRs, MitraClips, you know, things like that. We also do valve and valve mitrals. So pretty much you're looking at annual echoes right now. In the surgical world, they say if you had a bioprosthetic valve, you don't need to get an echo in the first 3 years, because you know they've been doing it for so long. You know how the patients do is fairly predictable. But the way the ACC guideline is now for structural interventions, I think they still want it every year until we see how this plays out the next 15, 20 years.
Yeah, absolutely. I think we have time for maybe one more question. How do we manage coronary artery disease in patients who are being evaluated for MitraClip?
I think the indicators to me for coronary revascularization would be similar to those in any other patient. There's no issue of safety of the MitraClip procedure with regard to coronary status, really. There's no hemodynamic stress on the patient. So you don't have to do anything with coronaries just to get through the procedure. If they have a Prox LAD lesion that's 80%, that itself could be causing shortness of breath and, you know, changes in the functional status. So that needs to be fixed before you even consider the clip. So, you know, if you have no idea about the patient's coronary status, yeah, I wouldn't say that that's somebody you're really thinking about implanting a clip on until you figure that out. On the other hand, you might have somebody that had a cath 10 years ago and then has had a stress test annually. There's just been no evidence of coronary disease. Now they have severe MR. Well, you may not even need another cath on that patient. But you have to have some sense of what the coronary status is to make the decision. And, you know, fixing severe proximal lesions is recommended.
Yeah, that was excellent. Yeah, I completely agree. Yeah, I think we've gone through all the questions that have popped up here in the chat box, and I've asked the questions that I had in mind for this lecture.
It's a good discussion.